Good morning. Welcome to the 2018 Resident Research Day. Yes, I know it's 2019, but we're just a little bit delayed on that. I'm so glad to see such a large group of people here. It's really fantastic to see you all. I'd just like to acknowledge that we are on the unceded territory of the Musqueam First Nation here. I'd also like to thank Eva Pang, introduce her to everybody. She is our program assistant, and she has done an amazing job of setting all of this up. So just a thank you to Eva to start. Okay, so we have an exciting lineup of presentations from all of our residents, and I think they're eager to get started. We do have an audience evaluation form. So we have our three esteemed judges over here on the left, David Moore, Eleni Galanis, and Charlene Black. So thank you to all of them for participating. They will be formally evaluating the presentations for the lucrative prize at the end. I note that it actually matches Dave's tie. I don't know if that was pre-contemplated. Yes, so they will be doing an evaluation, but we'd also like your evaluations, and that will get fed back to the residents as well. And we will be, I'm hoping all of you can stay for lunch. We will be trying to wrap up at about 11:45, giving a few minutes for the judges to be able to decide upon their prize winner as well as runners-up, and then we will be convening upstairs for lunch, at which point we will be giving the prize to the resident there. So, good opportunity to mingle and chat a bit. And with that, unless there are any questions, I think we are ready to get going. Okay. All right then. Our first resident is Sochi Hansen-Pastran. Away.
No, you got that. No, I think I'll project my face. I'm going to present on a project that I was a part of this past year. It's a global health project, and it's between university in Saskatchewan and province in Mozambique, in Nyumbani. Informally, it's just known as the Mozambique Canada Maternal Health Project. And although it's a bigger program and project that encompasses a lot of different things, one of their areas is research, and I'm going to be focusing on maternal waiting home study that they're doing right now. So to begin the presentation, I'll just overview a bit about Mozambique for those of you that don't know much about the country. And then I'll overview the MCMH project in general, and then go into the maternal waiting homes study specifically. It's using a realist evaluation, so I'll try to explain that a little bit, and then go into the methods. Currently, the project is right at its beginning stages, so we don't have results yet, so I'll overview at the end kind of where we're at, and take questions after that. So Mozambique is a low-income country in sub-Saharan Africa, right across from Madagascar. It's home to over 27 million people. The language is Portuguese, officially, although there are many languages spoken in Mozambique. 61% of the population lives on $1.25 USD a day, and it ranks 180 on the WHO Human Development Index. contextualize this, Mozambique has been recovering from hundreds of years of slave trade and colonial rule by the Portuguese, as well as decades of conflict and civil war. There's been recurrent devastating natural disasters and very strict structural adjustment policies that have affected the country. Its 24-year-old democracy is challenged with the task of improving the health of the population among a lot of high levels of poverty, food insecurity, difficult access to clean water and sanitation, and low levels of education for women. So that speaks to some of the challenges and contextualizes that. I think the chronic poverty and some of the rules around structural adjustment contributes to a lot of health sector underfunding year after year. Basically the outcome is that many health facilities lack adequate basic working conditions that are essential for appropriate care. So conditions even for the workers, livable wages, adequate staffing levels, and medicines and other inputs. Mozambique also suffers from an incomplete surveillance system. So this means that the population-based national data on vital statistics, for example, is often incomplete or not available. So decisions about how to allocate the scarce resources that the health sector gets may be based off of subnational data or single facility data. So because I'm going to be talking about a maternal health project, a little overview of the epidemiology around maternal health. The maternal mortality ratio is very high. It's 490 per 100,000 live births. And this is influenced by high fertility rates. In 2013, it was 5.2 children per woman as an average, and also influenced by endemic diseases like malaria, HIV, and tuberculosis. It's I think also definitely influenced by the lack of nutrition and food security, and the other things that I've been talking about, poverty and access to clean water and sanitation, as well as gender equity. From the gender-related determinants of health up there, here you see the Gender Inequality Index is ranked 146 out of 157 countries, so it's very low. And despite efforts to increase access to facility births in Mozambique, about 55% of women deliver in maternities with a skilled healthcare professional, and in the central and rural areas of the country, which are the poorer areas, that amount is less than half. So socioeconomic status definitely is a key determinant of whether or not a woman will receive care at her delivery. So this project is aimed at improving sexual, reproductive, maternal, and infant health in Mozambique, in the province of Inhambane, which is on the coast in the mid to south section. It's engaged on multiple activities, and formally the project is called Engaging Communities and Health Workers for Sexual, Reproductive, and Maternal and Newborn Health, but informally it's MCMH. The principal Mozambican partner is the Provincial Health Directorate of Inhambane, and the steering committee on the Mozambican side includes members from the Ministry of Health and 2 training centers in the province. They also partner with local NGOs. The principal Canadian partner, like I said, is the University of Saskatchewan Department of Community Health and Epidemiology. And the principal investigator there is Nazim Muhajareen. He's the center guy in the photo here at the office in Yavani, and he was my supervisor for the Global Health Elective I did this summer. So they have about three different pillars of the project that are kind of interrelated. One is community development, and they do things like adult-based education as well as micro projects, and have initiatives and partnerships with about 20 rural communities that they do this work with. The other pillar is kind of a health systems development. They do development, capacity management, and assets. There's lots of different activities they're involved in that regard. And then the third is research, monitoring, and evaluation. And this is to understand whether what they're doing at those two levels is meeting the needs and is effective. So there are 3 research studies kind of currently undergoing by MCMH. The first, we're exploring feasibility of using near-miss methodology to improve practice. The second, there's a project that's collecting women's experiences and women's stories. And this is to both engage women as well as to learn more about their lives and their issues. The third is a project studying the effects of maternal waiting homes on improving birth outcomes, and I'm going to focus the rest of the presentation on that aspect. So it has been estimated that 74% of maternal mortality could be prevented worldwide with appropriate access to emergency obstetrical care, but there are many barriers for women to access emergency obstetrical care. Maternal waiting homes have been introduced in a lot of countries, but in Mozambique as well, as a strategy for reducing delays in accessing emergency obstetrical care, especially delays in deciding where to deliver, as well as delay in transporting to a health facility that has a skilled attendant. The maternal waiting homes are basically facilities, like residential facilities, that are linked with healthcare facilities that are capable of emergency obstetrical care. So women at the end of their pregnancies can go and stay at the maternal waiting home in close proximity to the healthcare facility, and when they have onset of labor, they can transfer much more easily to the healthcare facility. This study is going to test whether maternal waiting homes work when these facilities are built well, so conforming to best practices by the WHO, and when they're managed and sustained in partnership with communities, as well as the healthcare system. The purpose of the study is to improve the prevalence of facility births in Yavani, and this is to reduce the risk of maternal and infant mortality. So MCMH has committed to renovating 3 maternal waiting homes in Yavani. Here are 2 of the ones that they're going to renovate. This is the before pictures of sites that I visited while I was there. Basically, the decision about which locations, as well as the policies and management of the new maternal waiting homes, has been guided by the steering committee of the Mozambican partners. So that includes key stakeholders and representatives from the Ministry of Health in Mozambique, as well as health facility administrators and clinicians and community representatives, including prospective maternal waiting home clients. The maternal waiting homes will be designed to meet minimum quality of care standards as defined in the WHO core mother shelter model. This includes safe infrastructure, including a building with 4 walls, a roof, doors, all of the kind of basics that we tend to take for granted in Canada, that you know, a lot of infrastructure in Mozambique just doesn't have, running water, etc. As well as space to accommodate a companion, which can be really important for women, adequate supplies and equipment, including mosquito nets and mattresses, those kind of things, consistent policies management and financial structures, as well as linkage to a healthcare facility capable of emergency obstetrical care. To assess the impact of the evaluation, we're conducting a realist evaluation, and this is a theory-driven approach where the unit of analysis is the program theory rather than the program activities. So this changes the focus of the evaluation from successful outcomes to the causal theory underpinning the program. So it moves the evaluation from the question of does it work to what works for who and in what context and how. Program theories are central to the realist evaluation as they provide a plausible explanation for the mechanisms that lead to specific outcomes within a particular context. And these are called CMO configurations, context mechanism outcome configurations. So basically the program theory is a plausible explanation for different CMO configurations. In this, the mechanism is defined as the reasoning and response of the actor facing the intervention or the program resources, so the participants basically. And key to this, the realist evaluation, is the idea of generative causation. So this is different than the causation that we're used to in epidemiology. Basically, it is the idea that it's not the program itself that causes the change, but it's the reasoning and response of the actor or the participant in the program within a particular context that creates the change. So the mechanism is what generates an observed relationship known as the regularity, and mechanisms can only be triggered in certain contexts. This gives our research the task of testing the theory of how program outcomes are generated by specific mechanisms and context. And using this framework, the maternal waiting home study will explore the context and underlying mechanisms such as a change in attitude towards maternal waiting homes at an individual level, or increased perceived value of maternal waiting homes at a health systems level that will influence the prevalence of facility births, which is the outcome we're interested in. The research questions are as follows. I think in interest of time, I'm going to just say that we're basically interested in the greater prevalence of facility births, or if there is a greater prevalence of facility births in catchment areas with maternal waiting homes, and versus catchment areas without or without renovated maternal waiting homes. And then there's some sub-questions there around mechanism and context as well. Sorry, I don't have more time to read those out. So I just want to go through the methods. So at its core, basically the realist evaluation method consists of constructing initial program theories, testing the theory using appropriate methods, usually mixed or qualitative methods, and refining the initial theory to end up with a middle range theory which can be applied in different contexts and can be useful for scaling up appropriate interventions. And it's an iterative process that's not linear. The study design consists of 3 parts. In the first stage, preliminary theories are created by doing literature reviews, and we'll do focus groups with key stakeholders as well to capture a representative sample of the key stakeholders' perspectives. We're trying to engage a wide range of community members, healthcare workers and managers, and provincial and municipal decision makers. After the intervention is implemented, quantitative and qualitative data will be collected and analyzed to assess whether or not the program theories are able to explain the observed outcomes. And I'll try and go through the data collection analysis quickly, really soon. The final stage will be theory revision and creating the middle range theory. So for the quantitative portion of the study, we'll begin by a descriptive analysis of the health administrative catchment areas and the facilities in the 3 different communities the intervention will take place, as well as the kind of control communities. Descriptive data will be obtained from a document review of the Ministry of Health, and facility information will be gathered from facility records. Data on other context mechanism factors is going to be derived from in-depth stakeholder interviews, and the stakeholders will be identified during the initial focus groups, as well as further candidates identified through snowballing techniques. And the questions will be developed to reflect research questions, and the program theories may be tailored to areas of expertise that the key informants have. We'll also be conducting 3 focus groups with clients of the maternal waiting homes and at the 3 different study sites to negate or confirm our understanding of the context differences and their perceptions of the renovated maternal waiting homes.
So, Jane, can you please wrap up?
Sure. Okay. Last slide here. So. So basically, like I said, this has kind of just been begun. I helped out with the literature review, which is now complete, and we're working on developing the preliminary theory from that, using the literature review, but also the focus groups. And so engagement with the community and stakeholders is ongoing.
So, Jane, I'm afraid we're going to have to. We're really, if you could just. Oh, we're really going to have to move on.
Okay. Okay.
Yeah.
Okay.
Yeah.
Good. Well done.
Okay. All right. So we're going to cut the questions down to about 3 minutes on this one because we are running behind. So is there anybody who has a question? Yeah. David.
Thanks, Sochi. That sounds, it sounds like a really interesting project. One thing I wasn't clear about, though, one thing I wasn't clear about is that, so has this intervention been demonstrated in other studies to be an effective measure, in which case you're actually just kind of evaluating the implementation of it, or is it really something that hasn't been studied before, and I wonder how that might affect, how your study design is constructed.
Thanks for the question. So from the literature review, it looks like there have not been very many studies looking specifically at effectiveness. However, like a systematic review has said that there's basically it's not shown to be effective or not effective. There's mixed results depending on the context, and it really is variable throughout the world. We were pulling studies from Latin America that showed that it was a very effective intervention. A lot of the studies from Africa showed that it wasn't, and specifically to Mozambique, the Ministry of Health did a review of maternal waiting homes in Inland Province, where we're working, and it showed that right now, because of the poor quality of the infrastructure and lack of engagement of community and involvement in community, as well as some other factors, including financial disincentives and difficulty transporting to the maternal waiting homes, there was a host of factors that made it very difficult for it to be, there was a lot of barriers for it to be effective. So basically, and it's interesting that you ask about effectiveness versus implementation, because initially when we were designing the project, I wanted to do an effectiveness study so bad, and and so our initial research proposal was like control communities, looking at all these outcomes, doing logistic regression, figuring all this stuff out on like about a variable level, but we turned to a realist evaluation because we really want to be able to understand kind of who this is working for and who it's not, and because basically we already knew that, things weren't working in Mozambique. So we wanted to see if, we use best practices, kind of outlined whether or not that would make a difference. And because our project is really all about community engagement, that was like a method that kind of honored that as well.
So my alarm actually goes off whether I put it on silent or not. So that's going to really be a bit of a whip for the residents. You'll know when your time is up. All right. So thank you very much, Sochi. I am now very pleased to present Conrad Sang, who, actually I don't have my list in front of me here, who will be presenting on the effects of a national student loan forgiveness program. So, thank you.
Oh, okay, good. Perfect. Can you guys all hear me? I'm a bit mumbly after dental surgery a week ago, so let me know what. Anyway, yeah, so I'm Conrad, I'm one of the third-year residents. I'll tell you about the project that we completed in family medicine, which are looking at the changes to the interest and matches to family medicine after implementation of the National Student Loan Forgiveness Program. Thanks for doing a land announcement earlier, Elena. So I do have some disclosures and everything here. So this research, after its completion, had a few funding sources, all to encourage knowledge dissemination. So none of them had a role in terms of how the project was actually done. But it came from the Department of Family Practice here, the Providence Healthcare's Department of Family and Community Medicine, the Lloyd Jones Collins Foundation, the North American Primary Care Research Group, and also the Association of Family Medicine Residency Directors of North America. And otherwise, I have no other potential conflicts of interest. So let's get into this. So we know 14.9% of Canadians reported that they don't have a family physician. This is from Statistics Canada data in 2014. This proportion has stayed pretty stable over the past decade, so there hasn't really been any change in this. In the year of the most recent data when this was all done was 2017, so from the CARMS data, which is a residency match system in Canada. In that year, in the first iteration of the match, because there are two iterations where everyone can go through, in the first iteration of the Canadian medical graduates, 950 of them matched to family medicine as their first choice, which accounts for 35% of the application pool. And then it goes up to 1,169 applicants in total, so 43%, and this includes everyone in the first iteration that actually would have applied for another specialty and preferred that one, but ended up in family medicine, so it was at least their second choice. We know that medical students consider many, many factors when choosing what specialty and what career to enter. So 3 general themes have come up, which include work-life balance, one aspect, patient-physician relationship, factors regarding the residency program, and then a whole bunch of other factors that perhaps are important for people who want to apply for a different specialty, but not for family medicine. To elaborate on this in terms of work-life balance, people are concerned about the hours of practice, the demands of being on call for the specialty, and also overall lifestyle flexibility. For the patient-physician relationship, people really value being able to practice health promotions at the individual level if they're entering family medicine. Being able to develop long-term relationships with their patients, providing comprehensive care, and not only treating just a patient, but also seeing their families as well. In terms of the residency program, the only one that really matters is that it is a far shorter residency program. There can be many reasons underlying this, including some people come to medicine a bit further along in life and just want to be done. Other people come in early and just want to be done. Some people might feel like they really need to enter the workforce to pay off debt, so a lot of reasons. And then things that are not important for specifically family medicine, the sense of wanting to become an expert, wanting a focused scope of practice, or wanting a practice that gives them a lot of procedures involved compared to, say, being a surgeon or some sort of proceduralist. Seeing immediate results from your actions, especially in clinical work. Being able to earn a high income and having that potential, and also perceived high status amongst the rest of your colleagues. None of these are very important, which I don't think are shocking when you think of that in family medicine. So with that in mind, I think there's not a lot of levers that we can use quite objectively to help incentivize people in their career track. So the question always comes up, can financial incentives work and move people to apply to family medicine if perhaps they weren't going to apply to it? So debt tolerance, it is subjective, it is emotional, it is personal. So we know that perceived debt, so how people think about their debt, do nudge students to apply for shorter residency programs. We know from US data that their medical students seem to be willing to apply to family medicine if they were originally thinking of something else, if there were incentives involved. These behavioral economic studies unfortunately aren't very clear in what is an appropriate incentive, how much you have to give, what types of incentive do you get. And we also know the US context is not our context here. So in the US, there are multiple specialties that are all 3 years, so they're all tied for the shortest program, including family medicine, internal, pediatrics, and a whole bunch of others. Versus in Canada, family medicine is by far the shortest at 2 years, versus every other specialty program, you're doing at least 5 years of residency, if not fellowship on top of that, either out of interest in some specialties or in others that you just reliably cannot get a job without at least one fellowship. So it's a bit different for us here. There are a few quite small financial incentive programs that are being used right now. But overall, when we look at any of them in terms of career selection, they are either not used at a large scale, and that they are almost never actually evaluated in terms of any effectiveness of how they're doing, what kinds of results they are achieving. So enter the National Loan Forgiveness Program. This is a federal program that was started in 2012. And how it works is it's up to a total of $40,000, but you do access it per year, so over 12-month cycles of $8,000 each. And this incentive comes as a tax, like basically it's not taxed and it's deducted directly from any outstanding federal student loans that you have. So any residency in the room, remember this if you're doing family medicine, because it is something you can access. There are 3 parallel arms, so I'll talk about the one specifically for family medicine residents, but there is an arm for family physicians who are already practicing, and then also one for nurses. So the one for residents, you qualify if you work 2 months rural or remote, and you don't have to live in that location, which works really well because most of us do not actually practice in a rural or remote location, and across most of Canada, those tend to be quite smaller programs. And here, like for example, was an urban resident, but when I went and did a rural rotation, I would have qualified. This is quite nice because it means almost every resident in Canada can access this at least once, because every program does have a mandatory 2-month rural rotation as part of the social accountability mandate at the universities. The only one where you might not qualify is if you're at the University of Toronto, because their urban sites tend to be quite a bit bigger than even their rural sites are a bit bigger than some urban sites at other universities, so it depends where you go there. But at every other university, basically you would qualify for this. And then at a lot of programs, you either actually have more than 2-month mandatory rotation and you have 4 months or 6, etc. Or it's not that difficult for a resident to actually take on another 2 months if they're interested in rural medicine, if they think they want part of that as extra exposure. So in total, over your 2 years, residents can relatively easily access $16,000 off of their federal loans as a deduction. So in the first 4 years of its launch, the media started a Freedom of Information inquiry and found that in only 4 years, this loan forgiveness program, and this is across all 3 parallel arms, had forgiven about $31 million to approximately 5,000 doctors and nurses. So looking at this from the perspective that this is a financial incentive for residents, I wanted to ask the question of, was the implementation of this program, did it change anything in terms of the interest and nudges into family medicine? So the methods for this interrupted time series, this is my conceptual framework of how someone goes through the process. So you have a medical student that almost always has developed educational debt along with training, both around medicine and also any training that they had beforehand. And I think now the national average seems to be about 100 to 170,000. Labor matching market and how it's all set up in Canada as a centralized process. And you come out on the other side, either heading into the red region where you've entered a specialty program, or if you move to the right, then you've entered family over to look at. And for the interrupted time series, we looked at multiple outcomes. So I'll only talk about 3 here today because most of them do tell a very similar story, and I didn't want to bombard you all with information. So 2 in terms of the interest of family medicine. One is just the number of applicants who ranked family medicine as their first choice specialty. This is the something I absolutely want to do and I'm hoping that I match to. And on the flip side, those that apply to at least one family medicine program, which largely is saying I'm willing to do this, and it might have been someone's first choice, it might have been someone's last choice, but I'm willing to match this if this is what happens at the end of the day. And then in terms of the match outcomes, just the total number of matches that did happen after the first iteration of the match. If anyone is interested to do this, I simultaneously fit two ordinary least squares regressions into the pre and post-intervention phases, used newlyweds estimators to get the covariance matrix, and then did subsequent complete Residency testing for autocorrelation to see if at the end of the day I needed to correct the models for a lag coefficient. In terms of the results, oh no, this is the only page where you absolutely do need the screen. There you go. Okay, so all three graphs are going to look like this. So there is a thin dark blue line in the background, which is the actual data. On top of this, you have the bolded lighter blue line, which is the pre-intervention linear regression, with the dotted line after the bar being what would happen if there were no changes that is predicted by the model. The vertical bar itself being 2012 when the program was implemented. And then the bold orange line is the post-intervention. So largely we're comparing where does the orange go compared to where you would expect it would have gone. So at the beginning of this in 2003, in terms of those that ranked family medicine as their first choice, there were about 300 applicants with 73 extra per year. There was a non-significant level change of 29 extra applicants the year that the policy was implemented. And then afterwards, a trend change of 57.8 fewer applicants per year with a P of 0.005. In terms of the second metric, measuring interest, those that apply to at least one family medicine program, again, the image looks similar, but just the axes have changed. So in 2003, there were 551 applicants with an increase of 131 per year up until the intervention was put into place, which that year there again was a non-significant level change of 15.7 predicted extra applicants on top of what you would have got, and then a trend change afterwards of 80.9 fewer applicants per year with a P of 0.032. And the last one I wanted to talk about, the total matches into family medicine. At the beginning of when we started looking at this cohort, 350 applicants with then 78.1 extra per year. At the intervention, a level change that again was non-significant of 22.7 extra, and then a trend change of 48.3 fewer applicants per year with P of 0.003. So the conclusions that we're drawing from this, the implementation of the loan forgiveness program, first of all, was not associated with any immediate changes of when it was implemented, but it was associated with significant decreases in terms of basically, like I looked at, I think, 9 metrics in total, and they all demonstrated that they decreased after this loan forgiveness program was put into place. Over this time period, we thought about it as a group. We've talked to other people across the country. We've talked to experts. We don't think there was any significant national level event that largely we could pinpoint like it was probably caused by this instead. There were multiple things going on at smaller scales in different provinces. So for example, I presume you guys have heard in the news, the Ontario Medical Association has had more and more instability in terms of their relationship with the government there. And one hypothesis could be that the medical students are having there's an erosion of their confidence in terms of what family medicine looks like as a career option, considering that a lot of the rhetoric right now is between very high earning specialists and what is their role in the system versus everyone else, of which family medicine is at the absolute bottom in terms of payment. In Alberta, for a few years, there was a rumor that people who came out of the Calgary and Edmonton residency programs would not be allowed to bill in those cities for multiple years afterwards. So you could work there, you just can't make any money afterwards. And this isn't exactly what people are signing up to. And that also didn't happen in the end, but that was in the news for quite a while. Concerningly, over this time period, we actually do know that the competitiveness of entering the residency match has gone up. Students are applying to more programs, they're having more backups, they're applying to more specialties in total because they're worried they see year after year that people are less successful in getting exactly what they want. So if you look at the data, people are applying to other programs more, and we were actually so shocked to see that there was a decrease for family medicine. So overall, there are multiple other physician incentive studies, not about career selection, but the majority of them do show a flavor that these incentives don't seem to have any significant effect in what you want to see. So perhaps people should think about this when they're designing interventions. Potential explanations of why there just wasn't an increase, which is what you would have wanted to see from this. You know, the gut feeling that I think most of us had was, when you look at this intervention, it probably wouldn't have actually made more people come in. It's not that much money when people, when medical students make no money. If you choose family medicine, you're doing residency for 2 years with modest salary, and then your trajectory of your income jumps up very quickly and quite a lot even in your first year of practice. So in terms of the sensitivity of when you actually have to implement an intervention, should be quite early unless you're giving them a lot of money. Further questions that come up, unfortunately there's no data that separate who exactly got what in terms of the loan forgiveness, and we know that it goes to doctors and nurses and residents as part of that. There's no data to evaluate if perhaps it drew more people into rural practice, which would be something nice to see. And then we also don't know when students finalize their career choice, which means when do you have to target them beforehand. So thanks, interested to hear what you guys have, because I've never presented this to the public community, only to family medicine or to government, so kind of want to know what you guys are thinking as well.
Thank you so much, Conrad, and we'll start with questions from the judges.
Can you remind me how many years of pre and how many years of post data you have?
So there.
For our listeners online.
Oh yeah, so in terms of how many years are pre and post data, so over this time period, the post would come up to about 5. It'd be a lot nicer if we saw more, but we're the thought of wanting to look at this is big because like in the media, it was the pre would have set up to be about I think either 10 or 11. We could have gone back further, but we do know that there were other changes that happened in the years before, so we didn't want to draw out the pre-intervention trend because that probably would have captured noise from other things that were going on in terms of what family medicine looked like as a career option.
Diana.
Thanks, Conrad. That was really interesting. I was wondering if we have some sense of how much of this is a distribution versus a quantity problem. So that being said, you mentioned the figure of 15% in the beginning of the presentation. Do we know what proportion of those people without family doctors are actively searching or wanting family doctors? And if we have a geographical breakdown of that gap.
Okay, thanks, Hannah. Really interesting because I personally would think of this as a wicked problem, as in we don't truly even know what the problem is, let alone how to solve it. So I think most people would agree that this is absolutely a distribution problem. You know, there are areas that you can live in Canada where, you know, the Canada Health Act just would relatively would not be able to implement in terms of the standards that you would like to see in terms of access. The statistics that people throw out in terms of how many people have a family doctor, of the 14.9% that say they don't have a family doctor, I would argue some of them actually don't necessarily need a family doctor, right? There are certain groups of populations where, you know, your health is about the same if you are just seeing a walk-in doctor because you have nothing going on, and perhaps if people don't need it, which is why the thing that comes up often is what are their targets of what, you know, the colleges or regulatory authorities think that people should be attached. So definitely yes, distribution. I think there's more controversy if we actually have a numbers problem. Some people would argue actually we don't have a numbers problem and it's just distribution. But it depends who you talk to and what kind of metrics they think are important.
Thank you.
Are there any other questions? Lynn, come on.
Thanks, Conrad. And you brought up some interesting thoughts about what could be going on here. How would you further assess this if you were to continue doing research in this area?
So this is something that is really, it's really complicated because there are multiple data sources, none of which talk to each other, and the quality of data that you can get is quite limited in that there are a lot of vested forces, both either from the learner's perspective or from the university's perspective or from, you know, from CARMs, from the colleges, that they don't truly want people to have all this data together. Because, you know, one of the conclusions that you could draw is everyone wants to go into a high-paying specialty, and that's not what Canada needs, and yet that hasn't changed. So I think what our avenues that probably people should figure out how to do is if you can somehow see who actually is going through the process and what choices they're making, which it's not released, that'd be nice. And actually, I think this is one of the few cases where, because the data does look like that and it's so partitioned, it'd be really nice to just do a relatively higher level surveys and of good rigor and good quality to actually see how much are, for example, financial incentives actually going to change someone when they're going through the process, which is also different from asking them on the other side. Now that you've made your choice, did you ever know that these things were available to factor into your decision and things like that?
Great, are there any other? Let's try that again. Are there any other questions? Excellent, well thank you again very much, Conrad. And next on deck is Alexis Crabtree, who will be presenting on the history of opioid agonist therapy use. And post-overdose initiation and retention among non-fatal overdose cases in British Columbia. We're having technical difficulties due to Mac use versus PC use.
Hi everyone, I'm Alexis Crabtree, I'm one of the RTs. My sincere apologies to anyone who has seen this data before. I can see some of you that I know have seen it. So I'm sorry, I'm coming off, in the R2 it's a clinical year, so I'm coming off a bunch of hospital rotations, and I think the hospitals are not the place for me, so it's a little older data, but I'll do my best to make it interesting. So I'm going to present for the history of opioid agonist therapy use among people who experience a non-fatal overdose in British Columbia, and then post-overdose initiation and retention onto OAT. This is data from 2015 and 2016, so a bit older. It's preliminary work, and I'll tell you at the end about what we're doing now as far as follow-up projects. So missing from this outline is a background section on the overdose crisis in British Columbia, and that's because I think there can't be a person in this room who isn't aware of the tragedy that's playing out on a daily basis. So I'm going to jump right into telling you about the unique features of this data set that we have to understand the what's happening in terms of overdoses and start to look at evaluating some of our interventions. I'll then go into some of the preliminary work. So looking at OAT among non-fatal cases, where the highlight is that there really are very few cases in treatment at the time of overdose. Looking at OAT initiation after a non-fatal overdose, and the key point there is that there's very few initiations among people who are out of treatment. And then looking at retention and repeat overdose among those people who were started on OAT after an overdose. And here the story is that there's quite low retention and then substantial morbidity and mortality. So to tell you about the data set that this comes from, this is from the overdose cohort. This is a series of linked administrative databases that were assembled as part of the provincial overdose response. So they're designed not with research in mind, but with epidemiology that's to be of use to the public health response. The data sources don't capture every overdose in the province, but they are designed to capture every overdose that comes to medical attention. So the data sources focus on, for the most part, opioid-related overdoses. So ambulance-attended opioid-related overdoses, emergency department visits and hospitalizations, calls to the Drug and Poison Information Center. And then illicit drug deaths is a little bit of a different category because the coroner's definition includes it's illicit drug deaths, so including no prescription opioid overdose deaths, but it is including stimulant and other drug overdose deaths in there. These data sets are linked together, so none of the overdoses are double counted. And that gives us, for the time period of this data set, about 10,000 cases. These cases were then taken, and 5 years of health history, prescribing history, and medical records were appended to each of the cases. And they're subsequently followed forward in time. So at the time of this, we have a shorter follow-up window. As we get more data, we'll be able to follow cases further forward in time. So for this analysis, because we're looking at post-overdose initiation, this is restricted to non-fatal cases. OAT in this case is, so opioid agonist therapy in this case is buprenorphine and methadone. So there are some specialist-led opioid agonist therapy treatments for opioid use disorder, such as Cadian or injectable hydromorphone. At the time of this data set, those weren't capturable in administrative data. We couldn't separate it out from people who were using those medications for pain, but in subsequent analyses we'll be able to. The decision making here it was about, for these last year, was about what counts as in OAT treatment at the time of overdose. And we've set that as having a dispensation of OAT within a month before the overdose. We say, someone's been on it in the past and they've had a month where they've had nothing. We consider that person out of treatment. And then post-overdose initiation is someone who is initiated, who is not in therapy at the time of the overdose and is initiated within 30 days after the overdose. So to look first at OAT use among non-fatal cases. This pie chart shows you status at first overdose, and you can see that 12% of people are what we consider in treatment. They had a dispensation within 30 days before their non-fatal opioid overdose. 88% of people are in no treatment at the time. And then looking sort of further at that 12%, the orange pie, we can say 1 in 4 of those people in treatment actually missed the dose on the day of their overdose. So if you look at this 88%, I think the natural question is, well, how many of those people were lapsed from OAT over a longer time period? How many of them had used in the OAT in the past, but just not in the previous month? And here we see it's about a quarter of them within the past 5 years history. We only have 5 years history on people, so maybe more of them in the past, but within 5 years, only 25%. So leaving 74% that we have no record that they've ever been on opioid agonist therapy for opioid use disorder. We looked at treatment interruptions here, and we can say, yes, I mean, most people had treatment interruptions during the time they were in therapy of at least 30 days. So we can look at this 12% as well, and I think the natural question that comes up with the 12% is, are those people who are overdosing on opioid agonist therapy? Are they overdosing on methadone, particularly, is the question that people ask. And without linking it to coroner data, which we can do for the fatal cases, we don't really have a great sense of that, but one thing we can say is that if we look at how many of these people, the overdose occurred within the first month, which is what we think is the window for high risk of overdosing on methadone, particularly, it's very few of them are within the first month of treatment. And among those that are in the first month of treatment, actually most are on day 1 or 2. They're not, you think about methadone, it's longer acting, you think about day 3, day 4, day 5, it starts to build up in the system, and that's when the theoretical window is of overdose, but actually it's people on quite low doses in the first couple of days, which gives the sense that perhaps it's the low dose in combination with some other product that's causing the overdose. It's not something that can be confirmed from this, but it gives a bit of a sense or a flavor. We look at among the people with active OAT, what other medications are they being prescribed? So I have them just in some of these other sedating medications. We know from research that benzodiazepines and Z drugs are associated with some interactive effect for respiratory depression, so an increased risk of overdose. And there's some recent work showing gabapentinoids and opioids are a concern. We also see that there's like quite a few other sedating medications, and quetiapine's the most commonly co-prescribed. So to skip ahead now, that's at the time of overdose. This is following people forward in time, looking at OAT initiation after their non-fatal overdose, within the 30 days afterwards, among the people, that 88 blue part of the pie, who were not in treatment. And here you can see what it is. Now understand this is 2015, 2016. But we see that it's about 6% of people after an overdose who were not in therapy are initiated within a month. Of those people, about 2/3 are reinitiations. They've been on it in the past and it's restarted, and 2% here are an actual new initiation. But you know, you could argue, I think, that, well, this 88%, the way we've defined overdoses in this cohort, does include some unknown number of people who have overdosed on prescribed medications. And so if we restrict the sample to just people who've had a diagnosis at any time in the 5 years before overdose of substance use disorder. So people were a bit more confident that opioid agonist therapy would be indicated. We would expect to have a higher percentage of people initiated after overdose, because these are people who are much more confident are, there's an indication to start OAT. And here, it's 11%. So it is higher, but still, I would say, a quite low number for one of the things we think is the most or one of the most effective ways of preventing a repeat overdose. So I think the question that comes up then is, did this differ between 2015 and 2016? We know that OAT use was increasing in the province, and this is particularly looking at among cases OAT use. So people who've experienced an overdose, OAT use over the time frame in question, and it's substantially gone up there. And we can see that no, there's no substantial difference. So it's a non-significant difference between the 2 years in terms of the proportion of people initiated into opioid agonist therapy post-overdose. The last bit is looking among that small part of the pie that are started on OAT after an overdose, what happens to them going forward? I'm going to spend a little bit of time on this slide because it's one of my busier ones. So this is looking at buprenorphine on this side and methadone retention over 6 months. On this side is people who were started within 30 days after their overdose on buprenorphine. And on this side is people who were started within 30 days on methadone. They can switch between those, so someone can start on day one, they start on buprenorphine, and at some point they switch to methadone. The darker orange on this side is the buprenorphine, and then you can see with the lighter orange they switch to, there is some switching over to methadone. This is retention over time, so it starts 100% of them are retained at the beginning, and we follow them forward for 6 months. And over here, this is the methadone start, so 100% are on at day one, and then following forward in time. These are the people who've remained on methadone, and these are the people who have switched to buprenorphine. And the story here is that there is actually a significant difference in retention between the groups. So buprenorphine has a lower retention rate at 41%, and there's quite a bit more switching to methadone, with the end result being only 29% of people are retained in buprenorphine therapy at 6 months post-overdose, compared to 43% have stayed on methadone, and 47% overall of the methadone starts are receiving OAT at 6 months out. But we don't start people on therapy for the sake of, like, retention isn't the goal. The goal is to prevent morbidity and mortality. So this is looking at repeat overdoses among those people who were initiated on therapy, and then also a group which is people who we're considering eligible but not initiated. So these are people who were had a diagnosis of a substance use disorder, and it is a rough guide here because people could have a stimulant use disorder. It's not opioid use disorder; it's stimulant use disorder. But we're considering them eligible, and then they weren't in OAT therapy at the time of overdose. By our definition, they could have been started afterwards. And if we follow those 3 groups forward in time, the buprenorphine starts, the methadone starts, and the people with a substance use disorder who weren't in OAT therapy and weren't initiated, we see there's no significant difference in overdose death between people who were initiated on OAT and those who are eligible but not initiated. And then, despite the differences in retention between buprenorphine and methadone, there's actually no significant differences in repeat OATs between the two, although the numbers here are quite small. I think a natural question out of this is, are there differences between buprenorphine and methadone starts, and are there differences between people who are eligible and not initiated? And, like, yes there are. I'll tell you a little bit about the next steps that I think we can do to get into that a bit. So in summary, in the time frame we're looking at in this data set, most people experiencing non-fatal overdose hadn't been in OAT in the previous 5 years. There were few overdoses among people newly initiated to OAT, and these were kind of in the early days of it at low doses. Only 1 in 15 eligible people were started on OAT within a month after the overdose, and only half were still in therapy 6 months after that. There was better retention for methadone versus buprenorphine, but repeat overdoses were actually quite similar between methadone, buprenorphine, and people with a substance use disorder diagnosis who weren't initiated after overdose. Some key limitations here that the cases weren't censored after overdose because we didn't have vital stats data at the time. There's not controlling for the indication of methadone and Suboxone. And I'm just gonna, I think it's a tight ship. We all appreciate it. So I'm just gonna talk about the next steps, which is we're working on modeling this. So a time to event analysis, now that we have vital stats data available. More recent data available, 2017 has just become available with the overdose cohort. And then looking at controlling for some of those demographic and health history differences between people started on methadone, Suboxone, and people initiated but, or eligible but not initiated. So thank you.
Thank you so much, Alexis. All right, we'll start with the judges here on questions.
I was just wondering about this thanks, that was really interesting, and I agree, that was a good strategy to skip the background, because clearly you need the time for other things. I was wondering about this group that were so-called eligible for OAT, and I wonder if that's actually really necessary to define that. It would seem like if you experience an overdose, is that not fairly close to being the definition of a substance use disorder?
Yeah, I can see the argument for that. My feeling is that in this data set, because we have cases where cases can be identified, for example, by EHS attended overdoses, and then those can be on people's own prescribed medications. So what I really don't want to get is a situation where you bias the results because you have older people who are on prescribed medications in combination with other things. They've taken everything as prescribed and they've experienced an overdose. I think it makes more sense to, because it is quite a large, the number of people who are not initiated is quite a large set. I think it makes more sense to restrict it to a more similar group and have that be the comparison rather than take the full group. We don't need the numbers for power. So I think it makes sense to have that more comparable group. It gives us more confidence in our results.
All right, one more question from the judges.
Hi. Implications you've got suggest the need for alternative strategies to OAT. Can you speak to that and what kind of recommendations you'd be making to public health authorities in that regard?
Yeah, I mean, I think that, to me, this raises some concerns, particularly the retention figures. I think that OAT is an important, it's an essential strategy, and lowering the barriers, I mean, I think that needs to come above this one, because that's the key finding, is that, like, what are those barriers? What can we do with this data set to identify where those drop-offs are, and what those barriers are? I think there's lots of room in this data to explore that. But I do think it also suggests that it's going to be difficult to get from 6% to 100%. And that suggests that other alternatives, what we're already seeing is overdose prevention site strategies to reduce people using alone, and then strategies to support peer-led initiatives and responses to the overdose. So we've already learned that people are doing test shots, coming up with other strategies around check-ins and things. I think supporting those seems like it will be key, because I just have some concerns that 6% to 100% is a difficult program.
I have a question here. Thanks. I was wondering if there's any opportunity to do an analysis like this that's geographic. I'm particularly curious in the percentage that did initiate OAT, where they may have been living, because I know it's particularly in 2015-16 there may have been significant access issues in some health authorities to even get the OAT therapy, depending on where you happen to be living. So is there any plan to look at it from a geographic perspective, or have you already done that?
Absolutely. It hasn't been done so far. There's certainly a plan to look at it. As you can see, the numbers are small enough when you look at the methadone and Suboxone initiations that we know it's going to be centered in the larger health authorities and the urban health authorities. So we get into a bit of a small numbers issue. I think with the new data that we're receiving for 2017, it'll absolutely be part of the plan to stratify the descriptive results, at least, by health authority and then by smaller geographic areas as well.
Because it would be great to be able to have some data to evaluate the significant efforts that have gone into increasing OAT access.
Absolutely.
From
and I don't expect
at a
the
regional
numbers,
level.
like I expect there to be a change in 2017.
All right, we have time for one very quick question.
Okay. When I was going through addiction rotation, first 2 days when I start somebody on OAT, they sometimes tell me, oh yeah, they're still using because they don't feel like that kicking. And I wonder, is there room to analyze practitioners' competency with this and maybe analyze whether or not the overdose after starting OAT changes depending on who's prescribing and who's starting with the prescription?
Yeah, I mean, we don't have that ability with this data set, unfortunately. We can look at starting dose, which I think gives you some sense, and that's a difference I noticed between practitioners that I work with, is people's level of comfort starting at a lower dose versus a slightly higher dose does change. So we can look at starting dose and outcome. I think that's a valuable thing to do, although it needs to really be led by clinicians or have heavy involvement from clinicians to guide that work. It comes with some problems about the people who are started at low versus high doses who do that. But I think it's worth doing. It gives us important information that could change guidelines and have real effects.
Thank you very much, Alexis. And next up before the break is Sean Sway. So we will be taking a 15-minute break after this. It says 20 minutes on our schedule, but just to get us back on time, because we're just a few minutes behind, we will just very slightly shorten the break. And Sean will be presenting on the construct of psychological safety in medical education.
I will. I just want to pull up my slides. Okay, here we go. Hi everybody, I'm Sean. So the question that I want to talk about today is psychological safety in medical education. We actually have an interesting researcher in the room with us, Professor Glenn McGarrett, visiting us from Center for Health Education Scholarship. I was hoping he would answer the tough questions, but he made it very clear that I'm the one answering the question. So the disclosure, I co-founded the initiative that we're going to be talking about today, peer mentorship in medical education. So in terms of background, I don't think it's any news to the medical doctors in the room that there's a lot of research on mistreatment in medical education during residency, belittlement, harassment, verbal, sexual, psychological. But the predominant focus on this actually suggests a paradigm where we say if we eliminate that, if we eliminate this sense of mistreatment, that will restore us to some sense of psychological safety. And while that may be true, it doesn't actually help us understand how we can build psychological safety on top of that. So what we actually need isn't just a negative definition of psychological safety, but what we actually need is also a positive definition of psychological safety, how we can actually enhance psychological safety beyond eliminating mistreatment. So that's the aim. We want to understand psychological safety in a safe environment. And onto methods. We're going to base it in a peer-assisted learning environment where it has been shown in academic literature that it's actually a psychological safe environment. And it's a peer mentorship and medical education program. It's a year-long peer-assisted learning experience. I think it's great, but of course I won't. So what it's based out of, it's 1 to 2 resident mentors per group of 6 medical students. And over the course of 1 to 2 years, we teach them workshops, we teach them clinical consults, walking through what it's like to be in a clinical world. We recruited student participants from this program. We conducted semi-structured interviews, and we prompt them with 2 main questions at the outset, which is, tell us a time when you feel safe, unsafe, and how did this actually affect your learning? And we reached saturation at about 8 students. And how we went about analyzing data, we first looked at items, things that may be of interest, thoughts, ideas, and then we said, oh, what are the patterns arising from there? And then we aggregated the patterns and we said, what are the themes that actually arise out of that? And we used what we public health people are probably really well familiar with. We look at interpersonal institution of the socio-ecological framework. Interpersonal obviously pertains to what's relevant to us. Interpersonal between people, and institutional, what are the rules or regulations or policies in this organization. And that's how we kind of started to set up the analysis. And here are the results. Here's an advanced preview of what I'm going to be talking about. So we're going to be talking about the core component of psychological safety, this idea that they don't feel like they need to self-monitor. I'm going to talk about that a little bit more. We'll talk about the factors affecting the sense of psychological safety or not, using the 3 levels that we talked about, and the consequences of feeling safe or not. So this idea of lack of need to self-monitor, it may sound a little challenging to understand, but really it's this colloquial idea of not feeling judged. When they don't feel judged, they don't need to monitor how they're doing. They don't need to monitor whether or not they're coming across as competent or not. They don't need to focus on projecting this sense of competence. And they have little concern regarding the consequences for their image. So this is a quote that actually defines it pretty well. And knowing that you guys, the mentors, weren't going to think I wasn't trying hard or anything like that. So I was willing to do my best. But if I didn't really know what I was doing, that you guys were there to help me through it and to teach me how to do it properly, rather than judge me for not doing it right the first time. So that's really the sense of feeling judged, whether or not they feel comfortable being who they are. Now, at an institutional level, what facilitates this? It appears that if they feel like there's no specific agenda, or there's no specific formal assessment or objectives that they have to hit, then they actually feel more comfortable, they feel safer. There's less formality and everything, and that in itself makes it safer. Like, we're having conversations with each other, and they don't feel, knowing that there's no specifics, and we don't have to hit some sort of criteria by the end of the day. Because if that's the case, then during the learning session, they will constantly ask, am I meeting that criteria? And you'll see that kind of coming out later on through the analysis. And I can see some of us medical doctors are nodding, because that is true. Now, on an interpersonal level, we have 3 things to talk about. Here's the first part. When they feel like they're understood and they're cared for as a person, not just as a student, there to absorb knowledge, not just as a clinician, there to learn some knowledge so that they can demonstrate it, but when they actually feel like the other person cares about them, when they actually feel like the other person understands them as a person. And here's a quote. These mentors, like whether they be second-year med students or residents, that they care about me as a student, as a future clinician, but also as a person with my own goals and dreams and what I want to do. The next part is when they feel like they actually know each other. Now, it's not just about other people knowing them, but whether or not they know each other, they're familiar with each other, whether or not they feel comfortable, and they know when they say something, the other person actually will respond in a certain way that they won't get cut down or be belittled, then they feel psychologically safe. So here's a quote to demonstrate that. You know how they're going to behave. You can anticipate maybe their reactions or their willingness to answer your questions. Yeah, just how they behave in the group dynamic. That helps you anticipate, like, you know, like, and you can tell the direct quote where you should ask, and is it safe to ask now? Is it right to ask in this context? So they can start to be a better judge of that. And then the last part, the positive and collegial environment. And I don't think this comes as too much of a surprise to us, because when we say, oh, you know, we're having fun in this group, we feel safer, right? So here's what they have. The overall friendly environment, like there's so many jokes thrown around, it's having a not very competitive environment where everyone has a best interest in particular to learn. So again, there's that competition, right? When there's that sense of competition, it starts to take away from the idea of positive and collegial environment. As opposed to, and this is going to be something that I think we medical residents are going to be able to associate with, in the hospital, like a group setting, and I know that someone loves cardiology and just asking all these intense questions about cardiology, I'm less likely to ask about my stupid question about why the left side of the heart is bigger than the right, or something like that. I kind of fade in the background because there's some gunner. I think there's a lot of comparing med school, at least for me. So for those MPH students, don't go to med school. And then there's an intrapersonal level where they start evaluating whether or not they're measuring to some standard that they think is appropriate for themselves. And this part's very interesting because they start internalizing the standards for themselves and they feel like they have to live up to that. And that can come from how they compare in the medical hierarchy. In second year, they feel like they're still doing it in first year. Or they feel like they've covered this in the previous year, so they feel like they have to know it. And here's some quotes, like I've gone through this, I reviewed this, and then I'm ready. I think for me, just the feeling of not being ready because I'm not prepared made the situation unsafe. So they expect themselves to prepare to a certain level so that they feel comfortable with the material and they feel comfortable in this environment. I mean, if the group were full of people who knew so much more than me, even in the year below me, I would probably still enjoy it, but I wouldn't feel as comfortable. So again, there's that sense of, am I feeling like I know my stuff comparing to other people? Now, what does it mean when we actually establish psychological safety? This part I find fascinating, because when it's not there, we start to care about how people look at us. We start to care about that, and we start to feel anxious, we start to feel ashamed, we start to feel inadequate. We start being very conscious of how we're doing in this environment. But when it's there, we don't think about that. We start to focus on engaging with the material, we start caring about, well, how can we learn more? How can we ask more questions to really get at this phenomenon? How can we be the best students that we can be? Because we're so absorbed in what's going on at this moment in time. And then we start to build increased closeness to the group. We start to feel, oh, we can actually talk to each other about subjects outside of the session. We're not just talking about, oh, cardiology. We're not just talking about pulmonology. We actually talk about life. People start asking mentors about career advice, about how I can study better. And that is something that is fascinating. Now, what does this actually mean in terms of discussion? Now, we're going to be talking a bit about towards positive definition, as I alluded to earlier. And then we're going to allude to two concepts that's quite interesting. Educational alliance, and also the idea of improved engagement in learning, the idea of flow, and also what it means for medical education. So instead of talking about psychological safety, which is applied in business setting or applied in nursing setting, what we also want to talk about is educational safety, which is the idea of psychological safety in an educational setting. And the difference is, in an educational setting, here, there's also, you feel like, I'm going to read it out first, okay? And I'll highlight what an interesting part is. Educational safety is a subjective state of feeling freed from a sense of judgment by others, such that learners can authentically and wholeheartedly concentrate on engaging with a learning task without a perceived need to self-monitor their projected image. So the key concept here isn't just that you're willing to engage more, but you also don't feel like you're being judged, and you don't have to worry about that. And that goes a step beyond what other people are saying, which is just, oh yeah, we can feel free to take risks interpersonally. But that there's an increased component of we can actually focus on learning at this point in time. And that's what sets apart for educational safety. Now, it also actually resonates with this construct of educational alliance. Some of us may not be familiar with the idea of educational alliance, but it kind of draws from the idea of therapeutic alliance. And educational alliance has been defined by Professor Regere's team as the learner's liking, trusting, and valuing of the preceptor and belief that these feelings are mutual, meaning it's not just you caring about the preceptor, but the preceptor actually cares about you. And it increases the commitment to learning and receptivity to feedback. And really, isn't that what psychological safety is about? It's a good representation that when people feel like they're understood and they can interact without judgment, it actually really starts to sound kind of familiar. And the idea of flow, when we say in psychological safety, people don't need to worry about how other people are perceiving yourself. You can focus on learning, you can be curious about the present moment, ask questions to really clarify your questions. That resonates strongly with this idea of psychological flow, where they can become fully immersed in a feeling of energized focus, full involvement, and enjoyment in the process of an activity. And it's marked by this idea of complete absorption in activity and loss of one's sense of space and time goes by so fast because you're so enjoying the current moment, and you're learning it, you're loving it. And this resonates with what we found for psychological safety, and it also minimizes burnout and improves sense of well-being, which is a key issue in medical student education and also in resident medical education as well. So what does this mean as medical education researchers is that at an institutional level, maybe what we ought to do is minimize formal assessments where possible. Interpersonally, we need to increase supportive relationships, and we need to minimize social comparisons. And at an interpersonal level, we should probably check in with our mentees to make sure they're holding themselves accountable to some level that's actually reasonable and not excessively so. So with that, I'd like to thank you for your attention, and after me, there's break. So, thank you. I'd like to take the judge's question.
Thank you very much, Sean. Sorry for the multitasking here. Yes, starting with some questions from the judges.
Thanks, Sophie. I'll take it later.
It shouldn't be too long. Thanks, Sean. Can you clarify whether this was, it was extremely interesting, but what this was, did you do an evaluation? Did you require ethics, or how did you go about gathering the information in order to come to these conclusions? And recruiting participants.
Yeah, so I skipped all that because I felt like the results and discussion was a lot more interesting. So yeah, there's definitely ethics. We went through the IRB read, it was approved, and then we basically sent out an email. It's kind of more of it's definitely a convenient sample because I know the students, so I just kind of emailed them and I said, hey, would you be willing to do this? There's no repercussions whatsoever if you decide to not do this. I'm not going to do this against you. You're still going to be part of this group. And they said, okay, we're going to do this. And then we conducted an interview over Skype and Google Hangout, and then I recorded it, and then I transcribed for interview. That was a pain. That was a pain. That was a pain. Yeah, but does that help answer the question? Okay.
So I'm acutely aware that I'm a judge here.
Oh, okay.
In an educational program. So
you did a great job, Charlotte.
Yeah. but so one of my questions is, you did a qualitative research study, right?
Yes.
You did a qualitative research study of an intervention of a unique program. I'm trying to make sure I understand it, okay. Of a unique program that introduced peer mentors, senior peer mentors. Okay, all right. So I just want to clarify that I understand that. And I had similar questions about the extent to which you generalize to medical training in general. Can you talk to me about how you can move from a very small pilot intervention to generalizing to medical training in general?
Yeah, I think that's a good question, and I think we need to use caution, especially in qualitative research. I think qualitative research, what we can say is that we reach saturation, and that means we have deep and rich, meaningful research in the sample that we have gotten. And the fact that we reach saturation means that we probably won't be getting any additional results within this sample. But if we're going to generalize the medical settings, now general medical schools may be a bit of a jump, because those people may, for example, not be as acutely aware of mentorship dynamics, because people we've accepted, they are quite interested in teaching. So they may be sensitized to that dynamic already. So if we are going to generalize to that aspect, I think we probably do need additional research. Yeah. Thank you.
That being said, Sean, what do you think the implications are for learning environments for public health residents and mentors, supervisors in this kind of field?
Oh, let me think about that. So going with the conventional sandwich approach, I think what we do well. So let's go back a little bit. So let's talk a bit about this construct, okay? I think in the interpersonal aspect, I think we do tremendously well. I think we have a great support amongst ourselves. And I think, like I was talking to some of our ones the other day, and they feel like they can talk to us very freely. And that actually creates a lot of very collegial environment, and we have a lot of positive support. I think institutionally, unfortunately, there's got to be some formal assessment. There's got to be some formal assessments. But the part that I really like about our program is every Friday we actually have a teaching session. And it could be more intense. We could have the evaluators quizzing us and saying, you know what, you're supposed to know this. How can you tell us more? But the way we're doing it right now is more of the pre-service telling us, just teaching us about things without evaluating us. And that's something that I think we can definitely keep up without this sense of formalized agenda, without formalized assessment, or at least maybe you're doing it subtly enough that we don't feel like we're being judged on the spot. And that's something that I think is worthwhile to keep up. And at an interpersonal level, I think that is something that we're still working through as we're revamping our residencies to make sure we're meeting the college accreditation requirements. And that might be something that we're starting to measure ourselves against the standard bar to make sure that this is not something that's excessive that we expect of ourselves. So those are the areas that I think would be worthwhile for us to focus on from a medical education safety perspective.
All right, we have one very quick question then.
Oh, sorry, I know that was quick. Thanks, Sean. I think this is really fascinating. I think it really kind of speaks to the theme of mentorship and the importance of mentorship, which I think is a big theme that's come up. I'm curious to know, especially when you kind of drawn into some of the business areas. So I'm thinking about this in the context of perhaps like organizations, which I think most of us in public health work in. What do you think might be some applications to like organizational structures and hierarchy that exist in the workplace?
I think that's fascinating. There's actually been a lot of evidence that's been done on that. I think the unique part where we're coming from is that in public health, not only do we do service in an organization, there's also that training aspect of things. So the first point that I want to make is that sooner or later we need to merge these two definitions, the psychological safety that's been done by Professor Amy in Harvard, and also what we're doing here. But also, I think what I'm going to focus on for my next point is, within an educational perspective, we can probably make sure that us, the mentors and the mentees are on the same page about what's expected, and also try to create a collegial environment. And that might be helpful on an organizational level that's actually focused on teaching as well. Yeah.
All right, thank you very much, Sean. Okay, so we are going to be taking a 15-minute break now, and we will reconvene at 10:45. And please, there's coffee at the back for everybody.
Do you want to do through my bag? I think it's time for coffee number
I know, but I would like to know more.
Also looking like your last year looks okay.
Just needed to put this in context of why it's No, because I don't think it's available to you. That's what you're asking. Oh, yeah. Otherwise, there would be no study available to everybody.
Is that a mentor?
I mean, in truth, well, yeah. I mean, in truth, which if you never go to Yeah, exactly.
Yes, yes. So it's always bringing out
How are you?
for future, yeah.
No, not too much. I'm sure it's like wrong, but yes.
And you know, of course, you're aware that we're moving towards this competency-based model, which means that you I think that's what we need to get across.
Well, so a lot of money's been going down. Parts of the David portfolio, when he was director of SPPH, No, sorry. And there's interest in having that service that is surveillance.
That's what I love about my Oh, that was, oh, I see, yeah. I thought you were going to say it takes time to get to. Oh, that's great. The only time we see that is occasionally on
Okay, everyone, if we could please start to take our seats, or actually please take a seat. Okay, everyone, we will now be starting with our chief resident, David McVie, and he will be presenting on framework for predicting phylogenetic clusters of HIV at high risk for growth.
Thank you. Only 2 more months, Conrad, and then surgery. So I'm going to be talking today about phylogenetic clusters of HIV and how we can predict or not which clusters are likely to grow rapidly. Before I begin, I'd like to thank some colleagues at the Center for Excellence in HIV/AIDS, Richard Liang, Jeff Joy, Richard Harrigan, and Art Poon, who is now in London in Western Ontario, who worked closely with on this project. I think we could all agree that surveillance is a core function of public health, and it always has been. This is one of the oldest records that I know of reportable diseases in North America. September 1798, deaths due to yellow fever. In some ways, it's not that different from what we might see today as we record reportable diseases. You have different areas showing down here and different dates along here, and for each case, there's a little bit of information about whether it was an adult, a child, a man, a woman, and so on. But in other ways, surveillance has changed dramatically. And one way that has happened in the use of, we don't see this from 1798, the use of genetic data and phylogenetic data. And the real power of using genetic data is it allows us to find clusters that we might not see otherwise, that may not be represented geographically or clustered in time, but they are represented by similarities in genetic factors, and so we can pick them out that way. And obviously in food safety, nod to the judges there, and TB also. Other cases in BC, we use phylogenetic systems. We have a very robust system for tracking HIV also. So the phylogenetic system in BC tracks about 200 different clusters of genetically related HIV. And practitioners in BC who work with communicable disease receive reports that give them information about these clusters. This is an example of one of the pages they might see. So there's a lot of information there. It represents different individuals who are genetically, or their HIV sequences are genetically related. And practitioners can use this information to help guide their practice and help prioritize the control of HIV. But that can be difficult because these clusters aren't always predictable. They move, they change, and they grow in different ways. So as an example, we can look at 2 clusters that I've shown here. For the first 100 months of their life, about 10 years, they look fairly similar. But as time passes, you can see that one cluster suddenly begins to grow rapidly while the other remains pretty static. Other clusters will behave like this, and they'll grow very quickly right off the bat. And remember, I said there's about 200 or so clusters of HIV. So when you consider really what the whole picture looks like, it can be tough to capture and to find the clusters that are important to intervene on and to monitor. They can get sort of lost in the background of many other clusters. So that gets us to the heart of what I'd like to talk about today. Is it possible to determine which clusters will become large versus which will remain small early in their life or soon after they form. As we approach this question, I'd like to sort of take you through 4 steps, the strategy that I used. First step is to evaluate the association between cluster characteristics and the cluster growth. So as an example, the ratio of men versus women within a cluster, is that associated with how large it becomes? Second, to test the ability of selected cluster characteristics to separate clusters that remain small from those that become large. As an example, this example we're talking about, the ratio of men to women, is that useful to separate large from small clusters? Next, let's say we have a characteristic that's useful. Can we determine a threshold value that best separates clusters that become large from those that remain small? So in this case, the example would be, what is the specific ratio of men versus women within a cluster? Is it 90-10? Is it 60-40? You know, what is it? And then finally, we want to loop back and test whether that threshold value actually would be useful in BC to practitioners monitoring HIV clusters. So a general comment about some methods. Clusters are constructed, the ones I'm talking about here, constructed from about 9,000 individuals. The clusters are made routinely as part of the surveillance system in BC. I've looked at a subset of clusters, 51 clusters. The reason I have a subset is they have to be at least 8 years old. We don't want clusters that are only a couple years old. They haven't had any time to grow. We don't want them to be too old, so I've restricted to clusters formed after 2000. Because before that time period, clusters weren't really growing organically. People were just being found and recruited and put into the clusters. And finally, what do I mean when I say a large cluster or a small cluster? I sort of use an arbitrary cutoff that represents the 75th percentile of cluster size. That's 10 members. So when I say a large cluster, it's one that's 10 or more. Small cluster is 10 or fewer members. Okay, so let's walk our way through this strategy here. So when we think about cluster characteristics that could be associated with the size of a cluster, a few things immediately pop to mind. You know, the viral load of people within the cluster, the percentage of people that are on ARVDs, antiretrovirals, the age of people in the cluster, are they young people, old people, how many of the members are intravenous drug users, how many are MSMs, how many are male, and then at the bottom there, what's the max growth rate of this cluster? Has it ever really grown quickly, or has it kind of always been bumping along slowly? I'll just say that when I'm using 5 members there, because clusters sort of birthed at 5 members. A cluster doesn't exist until it has 5 members by our definition. So 5 members is the earliest we can look at any of these characteristics. And hopefully you are waiting with bated breath there. Here are the answers. And interestingly, most of these don't really give you much information about how big a cluster is going to get. The one that does is the maximum growth rate. So what you're seeing there is the correlation value, and in parentheses, the p-value. If anybody has questions about why this is, I'm happy to address those at the end. But we can see there the maximum growth rate of a cluster is correlated with how big it eventually becomes. So we now have a characteristic in mind, the maximum growth rate. Let's test whether that can separate clusters that remain small from those that become large. Bit of a busy slide, so I'll take you through it piece by piece, but really what we're looking at here is the maximum growth rate, that characteristic, and the members at the end of 8 years. Because let's remember, that's what we're interested in, if it's big or small. The red dots are those that became big, so you can see they're separated right at 10, and the green ones are those that remain small. The heavy bar is the mean of that group. So you see the association there, and you also see there's a difference in the mean between those two groups. And that difference is significant using the Mann-Whitney test, which is the non-parametric t-test. You'll also see there is certainly an outlier up there, a cluster that became very large and grew very rapidly. I do have a technique that addresses outliers, and we'll talk about that in a moment. Okay, so we see that this characteristic separates these two groups. But what's the best threshold to use? We know that a cluster that has a fast growth rate becomes big, but how fast? So to answer that question, we use an ROC, or a receiver operator curve. So just as a reminder, this is a nice way to visualize a diagnostic test and how well it performs across a range of values. So on one axis we have the false positive rate, on another axis we have the true positive rate, and as we move along this curve, it's showing you the behavior or the performance of that value at different thresholds. we want to be up in that corner. We want true positives to be high. We want false positives to be low. There's different ways to kind of judge the best value or the best performance, but an easy way is to add up the sensitivity and the specificity and try to maximize that. And so that red circle shows you that maximum point. So at 0.6 members per month, that growth rate is the best way to separate clusters that become large from those that remain small. And you can see it performs anywhere quite a bit better than chance. And if we were to plot all those other factors that we looked at earlier, they would essentially lie on top of chance. And I have done that. Okay, so we've made our way through these 3 steps, but now we want to kind of get to the heart and say, does it work? Is it useful? Would this have helped us to capture or prevent growth of clusters in BC? So let's look at this for a minute. What we've done so far, we started with 51 clusters, and we used that data set to determine a threshold, 0.6 new members per month. It's tempting to take that back and say, well, let's test it, see how it does, but that would be circular, and of course it would work pretty well. We derived the value from those clusters. It wouldn't really be fair. What we really want to do is break that circle, take that threshold, and try it on a different set of clusters of HIV. I didn't have a different set of clusters of HIV, unfortunately. So I did the next best thing, which is to separate the clusters, take a subset of them, 26, hold aside the other 25, use these 26, as I've shown you before, to calculate a threshold, and then test it on those. Let's not just do it once, let's do it 1,000 times. Because each time we do it, we get a different set of those 26. And that's why I feel confident not worrying too much about that outlier, because many of those cycles, the outlier is not counted. And for those of you who are familiar with machine learning, this is a very simple form of supervised machine learning. So we've done this 1,000 times. Each time we do it, we get a sensitivity and a specificity. And then we can plot a histogram that shows us how sensitive and specific the tests are at each one of those 1,000 iterations. And you can see that overall the test is consistently quite specific and it's moderately sensitive. Sorry, other way around. Moderately sensitive and consistently quite specific at capturing these clusters. So remember, we did 1,000 trials, or 1,000 sort of iterations of that loop. In almost exactly half of them, the best threshold that separates large from small, exactly as we had thought from the beginning, was 0.6 members per month. Median sensitivity was 0.62, and the median specificity was 0.92. So I think this is good evidence that this particular factor, the growth rate of clusters, does have power to differentiate those that become large from those that become small. We used a technique that allows us to not worry too much about outliers, and we used a technique that allows us to be confident that it's not simply circular, that we're proving ourselves on our own data set. So now let's actually look and go back at some of the clusters in BC. So on this axis, cluster age and months. On this axis, cluster size and members. So these are clusters in BC that became large. And the red dot shows you where they would have triggered that threshold. There's sort of 2 different populations there. There's one here that grew very quickly right from the get-go. And I think it's great that this threshold would have been triggered very early on, very early in their life before they got large. There's another set of clusters, a couple here, that didn't do a whole lot, didn't grow rapidly for very long, and then seemed to switch into a rapid growth mode. And not too long after that period, they triggered this threshold, and they would have sort of come to the attention of this algorithm for detecting clusters that may become large. So just to sum up then, what I hope that I've shown you and convinced you of today is that looking at a simple cluster characteristic, we can get a good specificity and moderate sensitivity for detecting or predicting clusters of individuals with HIV that will become large down the road. In this case, 8 years down the road. And this offers MHOs and regional public health officials who work with HIV and work with phylogenetics a bit of a tool they can use right now, today. If a cluster comes to their attention and it's growing slowly, they can sort of monitor it, not worry about it necessarily too much, until it exceeds a certain threshold, at which case they may need to investigate or watch it more closely. And intervene if needed. So I think we're running a little, just about up on time. I will end there and just say thanks to the staff at the BC Centre for Excellence in HIV/AIDS, and particularly to Dr. Poon and Jeff Joy, who have worked with a lot on this work.
Thank you very much, David. All right, once again, we start with questions from the judges.
Can you summarize the exact, how you would describe this methodology to me?
Sure.
Who's not working in the lab?
The methodology of the
research.
genetic, the particular portion I did, or the?
Both.
Okay, so what I would say is that everybody who has HIV has a sequence of HIV infection. So their HIV virus has a particular sequence. And the more closely related their infection is, the more similar the HIV looks. Using that information, we can find people that have shared risk factors that we might not otherwise see. So they may be people that live in different cities, but their infection is related. That information is quite helpful for us because it allows us to know there's a shared risk factor and to address it. As people have that shared risk factor may lead to other infections. And that's what, as public health practitioners, we want to stop. As that happens, the cluster grows larger and larger. But many of these clusters don't actually grow that rapidly or that large, and some grow really, really rapidly. So the question, as we have all this data coming at us, these hundreds of related infections, how do we pull the needle out of the haystack, I guess, that is important for public health practitioners to address? And what the research here did is it looked at a number of different factors, found the one that was useful, and then showed that that could, in fact, help us to predict which ones would grow rapidly and which ones wouldn't.
Thanks, Amy. Can you maybe just go back one slide here? So your second point is talking about prioritization. But I was just kind of wondering, really in order to assess rapidity of growth, I'm just wondering how long you would need to follow a cluster before you could really distinguish between kind of these large versus small ones, which I suspect is probably a fairly long time. And then I guess the other thing is to think about, okay, well, what, in terms of interventions or that, what would public health people do differently compared to people in the small clusters versus the large?
Yeah, so those are very good questions. So I would say that your first question, which is how long do we follow these, we can look at this here. This is months, right? So a year is about here, 2 years is about here. So even the ones that grow quite rapidly, it takes a few years for them to really be growing. The idea, theoretically, the idea is that you could kind of bend these curves downwards, so you'd act here and they would come down. What would that action be? I think that's an important question. I would say that this project started actually before PrEP became universally or somewhat universally available. So the idea at the time was PrEP could be targeted. How can we target it? Rather than just targeting to individuals, let's target to clusters. So that was one intervention that was under consideration at the time, and the value of that intervention has diminished because PrEP is now more universally available. There have been instances in British Columbia with very rapidly growing clusters of concern where after a lot of thought and consideration, the cluster has been de-anonymized. So the people in the cluster have been identified and then engaged in care. That's another type of intervention. I would say that this could also act as a framework or an idea that can be taken to other jurisdictions that don't have the universal PrEP or other universal interventions that we have. So in regions of the world which are many, where they have access to some form of the system, but they don't have access to all the other benefits that we have, this system can be used to say, let's not just target people based on their demographics, let's target clusters. So that's, I think, the idea. So two things there. It used to be PrEP, and second is exported to other areas.
All right, thank you. We have time for one quick question.
Thanks for your presentation. I'm wondering, if you ever thought about using a relative threshold versus an absolute threshold, like in terms of the point, you mentioned the 0.6 members per month, but whether you considered a relative threshold, in terms of this analysis.
I didn't. That's a very good question. I don't have a solid answer as to why. What I would say is that, so there is, as far as I know, there's one other group that has done this sort of thing in New York. They have another solid, nice phylogenetic system. They have done something similar, and they did use a relative growth rate. So rather than saying the number of members per month, the number of members per member per month. Not dramatically more impressive, I don't think, but it's certainly something we could look at also.
All right then, please join me in thanking David for his talk. And we now have a remote presenter, Alex Choi. So Alex, can you speak up and let us know? Are you here? We may have technical difficulties, in which case we would have to go with our next presenter.
So sorry.
No, you are here.
Yeah, sorry about that. It was just on mute for a minute, and I had it in presenter view already. So let me just re-share the screen here. Let's see here. So I shared the screen there. Are you able to see my slides?
Yes.
Yes.
Yeah.
We are.
Okay, wonderful. Sorry, sorry, was there something in the background there?
No, we can, just saying that we can see your slides and we can hear you.
Excellent, okay. So I'll go ahead and get started then. Sorry, was anyone also making a comment there? Right, okay. So my name is Alex, and today I'm going to be talking about measuring the cost of public health eye gas intervention. A couple of things to start off with. I have no actual potential conflicts of interest to disclose, but I do want to say that this is a work in progress, and so I won't be able to share results as we're still collecting data on this. And for those of you who have heard me talk about eye gas before, for the sake of this presentation, I'll be focusing on the activity-based costing portion of the study, not the review of the BC data, the cost effectiveness analysis, the budget impact analysis, or the meta-analysis, just because that would be too long of a presentation. So to start off with, group-based streptococci are a gram-positive bacteria capable of causing both non-invasive and invasive disease. Invasive group-based strep infections, or IGAS, carry a case fatality rate exceeding 15% in the developed world and more than that in the developing world. In the 1980s, there was a suspected increase in the severity of IGAS, and around the same time, necrotizing pathway was recognized and characterized. And then, coupled with the documentation of increased risk of IGAS among close contacts, prompted several countries to publish consensus guidelines about the public health management of close community contacts. However, past risk estimates were based on an extremely small number of cases, because this is a very rare event. And if we look at the limited numbers of population studies available, we can see that it does seem like there is a higher risk of IGAS among contacts, but it's not really clear how much higher this risk actually is. Is it 200 times? Is it 2,000 times? The risk is very unclear, mostly because, again, we have very small numbers here. And this has led to the fact that there really is no international consensus as to how IGAS contact investigation and management should be done. If we looked at chemoprophylaxis protocols internationally, in the UK, they identified all close contacts and provided information to all of them, but they only provide chemoprophylaxis routinely to mothers and neonates in the neonatal period, although those over 75 will likely be included in the next iteration of their guidelines. In the US, there is no routine chemoprophylaxis. In Australia, it's highly variable. Some places, some regions within Australia, they chemoprophylax everyone. Some places they chemoprophylax nobody. Some places they do mothers and neonates in the neonatal period. And in Canada, we said that only severe cases warrant chemoprophylaxis of close contacts. So where did this come from? In discussion with members of the guideline committee and people who were public health practitioners who were heavily involved at the time, it seems like severity was used as a surrogate for M-type, with certain M-types believed to be more frequently the cause of severe disease. As we've learned more about IGAS, with cases that have gone on since the guidelines were published, there have come up a few issues with this. So first of all, while M-types 1 and 3 have been associated with more severe disease, there have definitely been case pairs with other M-types and other outbreaks with other M-types. And it's unclear if 1 and 3 are just the circulating strains, as we really don't know what the circulating strains are, and this would probably be very difficult and costly to find out. So how evidence-based is this approach, using severity to determine whether or not we're going to prophylax people? The trouble is that severity is actually not measured in most of the papers that have been published. And again, there's a small number of papers published with a small number of cases. However, in the papers that did report severity, when severe cases that produced subsequent cases were compared to cases which did not produce subsequent cases, the association between the severity of primary cases and the likelihood of transmission had pretty big confidence intervals on them. And the reason that I find this sort of problematic, personally, is that when you look at other markers of risk transmission, the risk ratios and the numbers needed to treat are much more persuasive. So this table is from a 2017 paper done in the UK, where we're looking at the numbers needed to treat and the risk ratios for mothers and neonates in the postnatal period specifically, and couples over the age of 75. And you can see the numbers needed to treat for mothers and neonates in the neonatal period is about 50. Couples aged over 75 is about 82. And you compare this to the numbers needed to treat that we got for severity, which is 394. And there potentially are some concerns. So why are we really interested in IGAS right now? Well, there's a couple of reasons. The evidence has changed. The guidelines are on the older side, but we're also interested because there has been this dramatic increase in the incidence of IGAS. In BC, we see this dramatic increase beginning in about 2013. In the previous 10 years, the incidence of IGAS is about 3.2 to 6.3 per 100,000. And as we see, in 2013, we get this really steady increase to the point where the highest incidence is now in BCH, where we have 11.2 per 100,000, and the next in Fraser, where we have 8 per 100,000. There's also a higher proportion of cases that are reported as severe, although the case fatality rate was lower. And along with this increase in incidence, there's been an increased need for contact management. So on a health workforce planning level and a public health resourcing level, this has created some challenges. And we've seen this echoed, not even just within BC or not just even within Canada, but internationally as well. Since the benefits of contact management, investigation and management are difficult to determine, again, because small number of studies, small number of cases, meaning that even if we, as we continue to study it, it will take quite some time to figure out the answer to this question. We also notice there's really no information about costs, which is important not only for health workforce planning, but also for things like building a case for vaccine on an international level. And in the guidelines, this is from the Canadian guidelines in particular, there is this sort of back of a napkin calculation. Maybe this is about how much it costs, but there's really nothing rigorous out there. And this is really, we found, a black box in terms of where this is internationally as well. So in conjunction with partners in the UK and the US, we set out to find out what are the human, financial, and material resources required for contact investigation and management, and what are the resource implications of different policy options. And it's fortuitous that because we do have these discrepancies in what our policies are, we can look at the second issue of what are the resource implications of all these different policies, and which is the best one, really. So we decided to do a multi-center prospective case series with collaborators in Canada, the US, and the UK. Looking around the world at what methodology we could use to do this, we decided on an activity-based costing methodology, which tracked which health professionals were involved, how much time was required for everything, and mapped that to costs and resources. We decided for the sake of clarity, and because we felt that this really was a different situation, we were going to exclude outbreaks and institutional settings. And so what we did is we reviewed the guidelines and we interviewed public health staff, nurses, and physicians in order to better understand workflows. From there, we developed a standardized time log, and we continued to use 11 standardized steps to our time log, which could be mapped to each step in each participating jurisdiction. So this would look a little bit different depending on which jurisdiction you're in. For example, we can look at step 5, risk assessment of community close contacts. For Canadians, this would mean the severity assessment. In the UK, this would mean determining whether someone is a mother neonate in the neonatal period. In the US, the calculus is a little more complicated. But in every country or in every jurisdiction that we are applying this time log to, each step of their workflow should be able to be mapped to one of these steps. Along with this, we created several tools which can be used to record time logs, including electronic and paper versions. And alongside all of these steps, we were including information that will help us to do the cost effectiveness analysis. We then held focus groups during meetings with public health staff who reviewed the time logs and gave feedback on contentability and wording clarity. And each country's lead was tasked with identifying participating departments. One thing that we came across early on is how on earth were we going to calculate sample size, because there really wasn't a lot of information, or really any information, to go off of to figure out what is our standard deviation here. And so what we decided to do is we were going to run a pre-survey survey, asking people how long did it take them to complete IDAS contact management for your last 5 cases. From there, we could figure out a standard deviation and hopefully power it to an effect size that detected a clinically meaningful difference in the amount of time needed to conduct contact investigation and management. And through our focus groups, we found this to be about 45 to 60 minutes. However, ultimately, we really do recognize that this is subject to feasibility. We unfortunately do not have external funding to fund this data collection. And so we're really relying on people to do this kind of off the sides of their desks. And so we really want to be aware of feasibility issues and not create a study that's too over for this collecting data. The hope is that we're going to drop all the information that we get from this, from this activity-based costing study into a cost-effective analysis. So this is a decision tree. Sorry, I recognize this is probably not readable for all of you. I apologize for that. But basically what this is this overlays the chances of transmission over top on the costs. And so what this should be able to tell us is what is the cost rented in BC and in these other jurisdictions as well, if they want to give us that EPI data. And from this, we'll be able to say not only how much is this costing us currently, but what is the most cost-effective policy. So if we're looking at both the risk of transmission and the costs of public health resourcing, what is most cost-effective? Would it be more cost-effective just to do contact investigation and management for the close contacts of all severe cases, of the close contacts of all cases, period, severe or not, of mother and neonates in the neonatal period, elderly couples, of all elderly close contacts of all cases, whether they're couples or not, or contacts with other high-risk characteristics. In doing this, there's almost too many people to thank, but I listed some of them here. So I gratitude to all the people who supervise me at BCH, to our international collaborators at Public Health England, as well as CDC, to C2E2, who has been helping us with the cost effectiveness analysis, to our Canadian collaborators, to my supervisors at BCCC, and to all the people who contributed to things like consulting on whether or not this is a reasonable way to calculate our sample size. So with that, I will actually turn it over to questions. Yeah.
All right, thank you very much, Alex. And starting with the judges again, Eleni.
Hi Alex, thank you for that and for presenting remotely. Very interesting and ambitious project. I hope you're able to see this through, or that the partners are able to see this through. I wonder, this is perhaps a bit of a philosophical question. Ideally, this is how we should evaluate all of our interventions, but based on the amount of work that's required, it's probably not feasible. It reminds me of some of the work that I've done in Enteric to try and ensure that that our programs and interventions that we recommend are as effective as possible, using the least resources possible. So I wonder, just using common sense, there's some of the interventions that you suggest, or some of the high-risk groups you suggest, that seem to be more accessible than others. Why did you decide to do a costing exercise rather than spend your energy and focus on trying to do an effectiveness exercise or study? So looking at, there's not enough data, or the data sets in the studies have very small numbers. Why not consider, maybe you have considered doing more studies around the effectiveness of the intervention rather than the costing?
Yeah, so to be honest, this is something that I excluded just for the sake of time. So this is a 4 to 5 part study, and parts 1 and 2 are exactly that. So looking at our BC data to see what the effectiveness of this intervention has been in British Columbia, as well as adding to the information on the number of case pairs, which is adding to the knowledge both on the risk of transmission, as well as things like, what is the window of intervention? Is this something that we actually can intervene in, just because some of these high-risk populations, I think I have it in my supplemental slides here. So, like one of the other questions that are coming up is, even if we think that mothers and neonates in the neonatal period are people who are at high risk, can we actually capture them with public health interventions, given that they typically present at the same time? So all of these questions are being answered, hopefully simultaneously, and I have to admit that there is a bit of a wrench thrown into the works when I sustained my concussion, because this is the work that I was doing at the time, trying to figure out more about this effectiveness question. The second thing that I was also doing simultaneously was a meta-analysis, again through C2E2, doing a more rigorous analysis of the existing data and combining that with the BC data to really answer that effectiveness question at the same time. And the cost effectiveness analysis that we will ultimately be doing should combine those two questions together. I have to admit, I thought that the activity-based costing study was the thing that was kind of the most new and I suppose like novel and researchy. So that's what I chose to present today. But this is a 5-part project.
Thank you.
Any other questions from the judges? Okay, we'll open it up to the floor then. No more questions. We have a question. Excellent. Getting my exercise.
Thank you very much for the presentation, Alex. It's Monica Naus here. Nice to hear from you. I was going to ask you, what was your assumption of effectiveness that you're using in your cost effectiveness? And through the process that's being undertaken, will you have all of the parameters that you require in terms of identification of or naming of contacts? There's always the question of which contacts were named and which contacts actually exist, and I'm guessing that you're not going to be able to figure that out. But at least for the named or identified contacts, what proportion of them in different scenarios might actually complete a course of prophylaxis, and because I think that's going to be important. And I think one of the limitations and the reason presumably why the Canadian recommendations go by severity of the index case is that it takes time to get EMM typing information. So even though EMM 1 is the most severe type, and one could stratify contact management on the basis of lab results, it takes some time to get those typing results. So it's not feasible to do it, and that's why the clinical presentation, I think, has been chosen as an indicator. But you highlighted very well a lot of the limitations in some of these assumptions.
Yeah, so, sorry, I might need to ask clarifications about the questions on the way, but I'll try and deal with them maybe in reverse order. So in terms of the time it takes to get EMM typing, that definitely, you know, that limitation, we're well aware of that. However, I think the bigger issue that we're trying to point out there is that we're not really sure that EMM type, if it does map to severity, we're not sure if it maps to risk of transmission of severe eye gas disease. And so, and because we have some evidence that that may not be the case, that is one of the things that we're calling into question here. The second question, asking about whether we're able to keep track of the contacts, I think is absolutely a good point that in our contact investigation and management, there may be contacts who are missed. We will be in our activity-based costing study keeping track of all the people who are given or are located. So people who are named contacts, people who are named contacts. So we will be recording information of all of those people, or at least the numbers of those people and their relationship. And we will also be keeping track of who was prescribed prophylaxis. We will not be able to determine who ultimately followed through with their entire course. So you're absolutely right. If some of those people stop taking their prophylaxis, we may not be able to detect that. But we're hoping that, you know, like with our standardized form, those things should be hopefully picked up. And sorry, I'm trying to remember, what was your first question again?
The question was really, what was your assumption about effectiveness? Because to do cost effectiveness.
Yes. Yes, absolutely. So this goes back to the meta-analysis that we were doing that is really looking at that effectiveness question. So the meta-analysis that we're doing is, and I guess there are many assumptions within this model. And I probably don't have time to go through all of the assumptions right now, but we could go through the modeling parameters. And the meta-analysis that we're doing was specifically to answer the question of what is the risk of transmission that we should be using in that first step, and then grouping that according to the relationship between the case and the contact, on case and contact characteristics, etc., using the existing information that we grouped together.
Okay, thank you very much, Alex. Please, everybody join me in thanking her. And next up is our last speaker of the morning, Cheryl Young, and she will be presenting on the feasibility of using machine learning predictive models for detecting TB and silicosis in a South African mine worker population. Thank you so much, Cheryl.
Yeah, so I'm Cheryl. I'm an R1 and I'm doing my academic year here. I'm doing an MPH. My supervisor for this project is Dr. Annalie Assy upstairs. And I actually broadened my title a little bit to include two data-driven tools, not just the AI model that we're working on, but it's, again, the same thing for compensation efforts for occupational lung disease acquired in South African mines. Okay, so historical context is really important for this project. Since the 1800s, South Africa's extensive mineral resources were its main driving force behind its economic development, such that for decades, it was the world's largest producer of gold, diamonds, platinum, many other minerals. And today, it still has almost half of the world's gold reserves and employs about 500,000 people. But mine work, it comes with significant health risks. Occupational disease is the leading cause of illness and death for this population, and lung disease in particular is the largest category of disease. And I'll be talking mostly about TB and silicosis in particular. So for South African mine workers, their rate of TB is about 2,500 to 3,000 per 100,000. That's huge. It's about 10 times the threshold that the WHO considers a health emergency. And with regards to silicosis, There are a number of studies that demonstrate that approximately a third of black gold miners have some degree of silicosis. And so we must ask why. And so this is a picture from the 2012 Marikana massacre. What happened there was 34 mine workers were shot and killed and many more injured because South African police opened fire on them because they were striking against their unsafe work conditions. And the message I'm trying to portray here is just that it's the decades of colonialism, of apartheid, and today's neoliberal era that continues to leave these mine workers with inadequate enforcement of engineering controls, inadequate enforcement of administrative controls where they work, and also just conditions where they that are conducive to disease, where they sleep and live. To make matters worse, these high rates of disease are coupled with historically low rates of compensation for mine workers, especially black mine workers. So in the 70s, the government did decide to give all mine workers, give mine workers an entitlement of a chest x-ray every couple of years, but it essentially only applied to white mine workers, and even though the majority of the mine workers were black. Finally, in 2012, after the massacre and after a lot of activist efforts, initiatives were launched by the government to start to address this. And by the end of 2017, a couple of years ago, about 100,000 mine workers were compensated, but so many more still have their packages unprocessed or not paid out. And this, from a article published by my supervisor a couple of years ago, it shows that in black is the shaded black is where the packages were processed but not paid out, because a lot of mine workers live not in South Africa but migrate from neighboring Southern African regions or countries, and some are non-compensable, so they have been processed but are non-compensable. The process itself of looking through a claim, it's really time and resource intensive because many pieces of info from the mine workers' medical history must be corroborated with their employment history to determine how much each claim is worth. And again, a bit about the history. Last year, there was this class action lawsuit where the mine workers won against the mining companies, and only last year were they mandated to start providing even more compensation. But because there's only so many medical professionals that can do this work, one doctor I spoke with when I was in South Africa a couple months ago said that there was only one occupational health, public health physician in all of Mozambique. So with only so many trained professionals that could do this work, and with about 500,000 mine workers, and over 1 million ex-miners across the entire Southern African region, the current wait time for finding out the result of a claim package is about 2 years. And so what the research team I'm part of is doing with the Ministry of Health in South Africa is twofold. One, we're developing a risk index, and the other, we're trying to validate an AI software, both of which to try to expedite the process of processing claims. So with regards to the risk index, we have access to a database of over 400,000 mine worker claim packages, some successful, some not. And we want to use a number of parameters that are their demographics as well as their employment history to try to develop this risk index that will give us a probability that each mine worker has an occupational lung disease. This is just a picture of just a very small part of the entire database. But preliminary, univariate analyses have shown already some patterns between things like age and number of years worked with diagnoses of silicosis, TB, and acistosis, and these are things that we kind of expect. And so the next step for this would be to do multivariate analyses to actually develop that risk index. With regards to the chest x-ray AI models, so we're trying to validate a model that will detect both TB and silicosis in a mine worker population. We already know that this type of software already exists specifically for TB, and it's already being used in a lot of low resource settings, but it's never been before validated in a mine worker population, which again is unique because it has such a high rate of other diseases visible on chest x-ray, such as silicosis. And so we did a preliminary trial. We provided 4 AI vendors with existing models that are already in use. We gave them the same set of chest x-rays, 50 normal, 50 TB, 50 silicosis. They didn't know the answer. And we calculated the area under the curve for each of them. So thank you, David, for already explaining what that. But basically what we found was that even though none of these 4 vendors have ever practiced or had their machine learn on silicosis x-rays before, a couple of them actually were able to retain a decent level of sensitivity and specificity. One was unfortunately not that much better than Chan's. And one didn't provide us with numeric probabilities, and I'll talk about that in a second. And one was even able to differentiate between, amongst the abnormal x-rays, differentiate between the TB and silicosis ones, which was pretty impressive, especially since it was the first time. And we did see that, comparing the AUCs, that they were statistically significantly different. The provider A being quite good with AUC of 0.9. So the next steps for this, that was just more of a proof of concept kind of trial. Now we want to do a slightly more nuanced trial where we're going to give them more chest x-rays, give them x-rays that have both TB and silicosis together on the same patient, provide some time limits, and just redo it and hopefully select this one model that the Ministry of Health will use. Another thing that we're thinking about is if our ultimate goal is to pick the best model to get compensation to those who need it fastest, we don't need to pick just one. For the vendors, it's a competition. They just want this contract. But for us, if we have found that combining the first vendor and the fourth vendor actually improved the AUC statistically significantly from 0.9, which I mentioned earlier, to 0.965. So that's another thing to consider. Another thing would be choosing an acceptable level of sensitivity and specificity. So as David explained earlier, you can pick a maximum threshold at which you maximize the specificity and sensitivity. But when we're looking at this use, the last thing we want to do is to send someone home who has TB, send someone home without compensation who actually has silicosis. So we actually want to aim for a higher sensitivity because the consequence of false negatives is worse. And so what we tried was, given one vendor's AUC, this is the threshold that they picked that was maximum, but if we chose a threshold that had better sensitivity, yeah, we lose a lot of specificity, but our false negatives drop significantly. And my last point is just that this AI software shouldn't ever be used alone, and even just looking at data-driven tools, not even thinking about health system strengthening and other bigger picture interventions. Just looking at these data-driven tools alone, that's where the risk index I was talking about earlier comes from. Even with a really good sensitivity, you're still missing out on so many people when there's over 1 million ex-mine workers in the entire region. So that's where the risk index comes in, and the more information we get, the more accurate it would be. Yeah, so I'm just concluding here with just a comment about how mining companies are starting to be held accountable to past actions, but just the sheer volume of information that needs to be processed, it's a really big barrier to timely compensation. And so using these data-driven tools, the preliminary results are promising, and so clearly we need to work a lot more on this, but the ultimate plan is to just get compensation and medical attention to those who need it most. That's it.
Thank you so much, Cheryl. Okay, once again, we'll be starting with questions from the judges.
Thanks. It sounds like a really interesting project. I mean, I was just wondering about is when you're doing, I mean, I understand that what you've done already is just preliminary stuff, right? But you've kind of fixed your prevalence of disease at roughly 50%, right? Is that you had 15, how many x-rays were there? It was something like 15
Yeah.
TB, 15 silicosis, and then 30?
It was a third normal and 2/3
Yeah,
abnormal.
okay, so you've actually fixed
Yeah,
it
we
at
did.
66%, right? So your positive, so that's really gonna affect your positive predictive value when you run this to the next level. So is that part of your plan, that you're gonna include a much larger proportion of normal X-rays that would kind of reflect more accurately? I mean, prevalence is very high, but it's
Yeah.
not 66%, right?
No, absolutely. So the plan for a further trial, even just trial 2, we want to do this multiple times. Because we have access to this huge database of real X-rays from mine workers or compensation claims that have already been processed, where we know the result, we do want to have a trial where we're doing more, a larger number of X-rays, but also more reflective of the true prevalence. So absolutely, yeah.
Okay, any other questions from the judges? Okay, I will be moving to the audience then.
Thanks, Cheryl. Really interesting presentation. I just have a question about. Like Canada's mining involvement in South Africa, and if you know if there's specific Canadian mining companies that are involved there, and if they're like at all held accountable to being a part of the compensation, like if they're also compensating mining workers affected by their actions or lack of action, especially kind of around the violence that you explained.
Yeah, that's a really great question that I asked myself yesterday and just didn't find the answer to yet. I'm not aware of specifically Canadian mining companies in South Africa, but I do know that there are about half a dozen Southern African countries that do have mines, either partially or fully owned by Canadians.
Mm-hmm.
But I should look specifically into South Africa for sure.
I have a quick question. Are people with TB being compensated also?
They are, yes.
So is the idea that would they be treated then based on the algorithm, or would they sort of be flagged and then need to undergo definitive testing before being treated?
So I guess our team isn't specifically working on the implementation of the medical attention part of it, but what I do know is that the ones who do get screened right away at the mines, they would be, first of all, they're not allowed to work anymore, so a lot of workers don't want to get treated, screened at all. But if they do get test positive, then they do get medical attention. I guess this work is mostly focusing on the compensation of silicosis, especially, and ex-mine workers.
This might be too early, but I'm curious around the risk index algorithm and how you see that potentially interfacing with some of the work that has been done so far.
Some of which work?
The AI work that has been done. Like, do you see it, changing how the AI operates, for example, or does it determine how, for example, people are identified? Can you describe that in some detail?
That's a good question. I'm not really sure where this is going to go further down the line. I imagine that it would be used together to come up with the most accurate prediction, and I imagine it working together would make it better. But yeah, sorry, I guess I haven't really thought that far down yet.
All right, thank you very much, Cheryl. That wraps up presentations for this morning. I really want to thank the judges for their work in trying to judge between those. I'm glad it's you and not me. I'd really like to thank David, who has been, as the chief resident, has really been instrumental in making sure that that there's coordination between me as the new program director and the residents, and so thank you, David. Also to Tina and now Eva, who have been fabulous in setting this up and making it work seamlessly, along with Stefan on our technical side. So thank you to all of you guys. And lastly, thank you to the residents. I am so impressed with the quality of the presentations. I'm grateful for people who didn't have to present, that are presenting, coming in off of leave, or presenting in first year. So for all of you, that was a very informative and a very interesting morning, which really showcases what great, the future, the potential of our specialty, and just how that collaboration between, the supervisors and residents, what that can end up with. We did have some technical difficulties for a couple of individuals, but hopefully that the people online were able to listen in. I think we had about 5 people in as well online, so it was, so thanks. Yeah. So lastly, thank you very much to the audience and everybody who came out and just showed what a great public health community we have, and how we mutually support each other. So at this moment in time, we are going to wrap up the evaluations. Eva is at the back. Actually, just leave them on the front table, please. Leave them on the front table, please. And there'll be a brief intermission right now for the judges to make their decision, and we will meet upstairs. So if the rest of us could start making our way upstairs to the lobby where Eva has set up lunch. Thank you so much.
Were they like, dear Cheryl, ABC is one.
No, so we did they actually with all the other vendors. But then that one just said, this is not possible. So that's what we're going to do. I didn't want to go to a trial too. We like made them we thought of today or something. Today don't Yes.